Hi everyone, it's 4 o'clock here on the eastern side of the country down in Miami. This is Jacob Kirsch, I'm current president of NASCI and want to welcome everybody to our very first webinar for the NASCI's Curious Cases. Before we start, just what I think might end up being the dynamic of this very first webinar, I prepared a few cases that we're going to be going through. It's going to be show and tell, and please, I would like anybody with a question or a comment just to chime in. Otherwise, try to stay on mute so we don't have a lot of background noise as we go through the cases, but everybody's welcome to participate for sure. I know a lot of my colleagues from NASCI are going to be online, so they can also help answer some of the questions and talk about their personal experience in their institutions. I also put together a few slides to accompany some of these cases to try and get some didactic information that may continue to happen in the future for some cases, for some not. But, you know, this is an evolving and learning experience for all of us. So why don't we go ahead and get started. Let me try to move out of this loop of video here, and we'll start just going straight to the cases. First case that I wanted to show you guys, this is a 50-something-year-old male. Was working at the shop and where he works, some cart repair shop, and started having some chest pain and shortness of breath, and came to be seen. And I think even from the thumbnails here, you can start seeing some of the abnormalities. So I'm just going to scroll slowly through it. And we see all these squiggly little vessels here in the upper mediastinum around the arch vessels. And then some very prominent squiggly vessels, just tortuous vessels all over the upper mediastinum. I think the first thing that is very strange and clear to us is we have this large vessel coming out of the pulmonary trunk right at the level of the sinus of the pulmonary vein. So large vessel, tortuous vessels coming here, and seems to bifurcate and follow an interventricular grooved distribution and an AV groove distribution, so an LAD and circumflex distribution. And then we see also the RCA here out of the right coronary cusp that's markedly dilated and tortuous, going all the way around, significant collateral flow and communication between these engorged coronary vessels. Look at the septal perforators, also enlarged and communicating the anterior and inferior perforators, so just bridging and again giving all this collateral flow between the left-sided and right-sided cardiac circulation. Just going back a little bit again for everybody to see. And now the other thing that's important to notice here is we have this vessel here coming from the pulmonary artery, very proximal, but we have nothing coming from the left coronary cusp of the aorta. So I think this is a pretty clear case of a very nice example of an anomalous left coronary arising from the pulmonary artery. So a very important coronary anomaly in an adult. These patients usually present during infancy, and there's a small percentage that have enough collateral flow that don't have the physiologic same situation as that, most of them, and can survive into adulthood until they're putting under enough stress as they start showing signs of ischemia. Again, important to notice all the collateral flow, and this vessel, I want to point out that it arises very close to the origin of the pulmonary artery, right at the level of the above the valve. Let me point something out that's going to come in handy as we see other cases and some of the slides that I prepared. We have here one of the commissures of the pulmonic valve, and we have here the one from the aortic valve, and you see they're pretty much one next to the other. So we're going to talk a little bit about embryology of the valves in a second. So this continuity is important to remember, to understand that embryology of the coronaries. By the way, we have this other larger than usual vessel coming here superiorly to the RCA, which is there. So this is your conal trunk. It goes anterior to the conus. Some patients will have a small left conal branch as well and may create an arch across them too for collateral flow when there's proximal stenosis or strictures or tight plaques at the origin of the LAD, left main, or the RCA, depending the case. So it can help as collateral flow. That there's a name to that. It's called the arch of Busens. Just some cool volume rendered images here. Again, to look at the degree of dilatation and tortuosity of those coronary images here. So very, very nice example of an ALCAPA, or anomalous left coronary artery arising from the pulmonary artery. Case 2 has a companion here, angiography. Let's look at the CT. Let's look at the angiography first, actually. Let's do that. And let me see if we can play this as a movie. So we see here in this patient, I don't know the age of the patient, but it's another adult, selective angiography of the right coronary artery, which also appears dilated, very similar to that very first case that we saw. So we see flow that starts to go through collateral flow and communicate with the left system and draining into the pulmonary artery. So there's a still phenomenon of flow from the left, stealing flow from the right, which is very characteristic of these pathologies of anomalous left coronary arteries arising from the pulmonary artery, or ALCAPA. Let's look at the CT on this patient. So we have two recons. One looks at the left-sided circulation better than the other. Let's see, this is one looking at the left, I think. Let's just scroll down. Interestingly, there's also another anomaly here, or anatomical variation, we can say. It's the right subclavian. You see it has a retrotracheal and retroesophageal course, and it's arising from the distal arch. So instead of being the first branch from the arch, is the last one. So that's an aberrant right subclavian artery. And then it crosses over towards the right upper extremity. So that's just an incidental finding, I guess, in this case, that we know from the angiogram that has other more important issues. So again, not as obvious as the other one, but we can see here that the left coronary is coming out the pulmonic artery here, the pulmonary artery, very proximal to the valve, and immediately coursing towards an LAD distribution and giving here branching into the circ and some obtuse marginal or diagonal branches there. Again, some engorgement of the coronary arteries and a lot of collateralization. The right-sided circulation has motion artifact on this image. If we open the other recon, the 80-some%, I think the right-sided circulation looked a bit better. And not much. But again, we see here the left, very clear example, and we have the confirmation from the angiogram there. So another nice case of ALCAPA. I don't know if this is how real this is or not. You can see the subendocardium in the distal left ventricle. So there's some cardiomegaly, some dilatation of the left ventricle, but also some subendocardial low attenuation. So this may be some either ischemia from the first pass perfusion of the injection of contrast for the CT angiogram. And it's pretty consistent in that distribution, so it's probably real that the patient has some subendocardial ischemia to go with this still phenomenon related to the ALCAPA. So that was case 1 and 2. Let's see what's case 3. This patient actually is a case that was shared by Dr. Travis Henry from UCSF, a good friend of Nasky and mine. And again, very similar findings. I just wanted to go through a bit of the spectrum of this pathology. Not only that, here you see the same still phenomenon that we saw on the angiogram on the other patient. And you see a blush of the contrast going into the pulmonary artery as it opacifies the non-opacified blood in that cavity. Again, engorged septal perforators, a lot of collateral flow. So again, a very similar finding. This patient had surgery right after this CT examination. I don't have the post-op images, but I know that the patient had reimplantation. So they went in, they ligated here and reimplanted the left main into the aorta. In this case, so another nice case of ALCAPA. And as you've seen, one of the things that I wanted to point out is all cases, you can see the anomalous coronary arising very proximal to the valve, very close to the proximal most RVOT. Another adult patient, and you start seeing all these little collateral vessels all over the mediastinum, so there's something going on. And as we continue to, I'm guessing all of you are noticing that there's something missing. It's usually harder to notice things that are missing, that things are there just that are not supposed to be there. So we see the main pulmonary artery, we see the left pulmonary artery, but there's no right. So there's a congenital absence of the right pulmonary artery in this patient. And that's why we have all of those collateral vessels there. But the other thing that we see here is that the left coronary artery is arising also from the pulmonary artery. So there's a combination of congenital defects in this patient. So congenital absence of the right pulmonary artery and ALCAPA as well. And you're going to see again all the vessels very engorged with a lot of collateral flow in the heart as well. Let's see, these are a little bit thicker images. So
Hello, Mr. President.
yes, how are you, doctor?
Can we comment or just listen?
No, please do comment as much as you want. This is your forum.
Okay. Sounds wonderful.
You have any questions, Karen? Or just wondering?
No, I know that case. That was from 2002, a long time ago, and it was successfully reimplanted.
Yes, I gave your institution credit. Don't complain. Yeah, and you see there's associated decreased volume loss because of that lack of blood flow to the right lung. That's a long-standing issues with that right lung. So you remember that case, Karen?
That's our case too.
Yeah. How did they treat that case? They did reimplantation as well?
Yeah, they did. Yeah, it was very short distance, as you mentioned. So that's what you got. All the cool cases.
I don't know. This is another very nice case. This is courtesy of Howard Mann from Utah. Howard's also a great friend of Nasky. Let's start with some of the angiographic images here. Let's see if we can play them. So this is a selective injection in one of the acute marginal branches, but it has some retrograde flow into the RCA, and you can see all the collateral flow and the still phenomenon into the LAD, and again the pulmonary artery right there. Let's look at this movie here. There you go. So injecting to the LVOT there for an aortogram basically, but with flow into the RCA. And then you can see all the collateral flow and then into the pulmonary arteries right there, right on left. So again, the same phenomenon, just trying to look at it from different cases, but the physiology is, of course, the same or very similar. It's a right coronary injection. You can see here the pulmonary artery through retrograde flow immediately. Let's look at the CAT scan. This is an interesting case because this is a kid, this is a pediatric patient. And you can see he has some lung issues right away. The kid is had a trach. So significantly decompensated by the process. And what's very interesting here, had a PDA that got ligated there. Let me see if we can make this just a little bit brighter. So there's the LED here crossing over. And it arises for a slightly more distal pulmonary artery here. And you're going to see as I scroll that it curves around and it actually goes into the aorta, has an intracameral course or so intramural course at least into the aorta. So when you look at the angiogram, you know that there is no communication between them, so it's not shunting there, but it definitely goes within the wall of the aorta and maybe into the cavity a little bit. So it has, I guess, the equivalent of an intracameral course, which we often see in, not often actually, but we do see in the cardiac chambers, but we're seeing that in this anomalous coronary as well. And Howard also shared this this paper here, so we can see it. So there's has been publications about this when these coronary arteries have an intramural aortic course, and it's a series and how they dealt with those patients for the reimplantation of the left coronary into the aorta, or they just do an unroofing of that intramural course. So it's an interesting rare variant of a rare coronary anomaly. So I want to share with you just for a second. I put together a couple of slides because I had a couple other cases, but I figured it'd be easier just to show them like this and show and tell. So the first, and please try anybody who wants to answer. So what do you think about this? The origin of this coronary? Normal, anomalous. What sinus is this coming out from? No takers? Dr. Vargas, are you there? Okay, I was supposed to be show and tell, so I'll show. Okay, so actually we'll show in a little bit. We'll come back to the image once we go over some of the slides. So this is my attempt at drawing the contour.
Muted. Unmuted.
It starts to pinch at the middle, and like this. Again, sorry about my drawings. And continues to pinch at the middle during embryology development until it becomes two separate vessels: the aorta and the RV. The aorta on the left and most posterior, the RVOT or pulmonic valve, slightly more anterior and to the left of the patient. What's important is then, and I pointed at this at the very first case, where the commissures come together. This is a constant in every case. I'm trying to label here this in blue. So every time we have the commissures, they will come together at the site where they pinched off. So this is always going to be a constant. They're going to be one next to the other. And it's a good way to try to determine where is the left coronary cusp and the right coronary cusp, because that's going to be in relation to the pulmonic valve to some degree. And the vast majority of patients, normal patients, of course, the vast majority will have a left coronary coming here and the right coronary coming here. Again, These are horizontal here, but of course in the body, this is more anterior, this is more posterior. So this is an important constant. And if you look at some of the really old cardiac pathology literature, this a landmark paper by Dr. Richard Bragg, who's the father of cardiac pathology. He was over at Mass General, and he has some really fascinating papers. Um, you can see those little two eyes where the coronaries are supposed to be, and throughout all sorts of cardiac anomalies, all of them, that relation of where the commissures are supposed to meet, it's constant. It's always there, and where the coronaries are supposed to be coming from is going to be constant to that commissure. So again, uh, this helps us understand and get our bearings as we're seeing some complex congenital heart disease cases. The only um, exemptions to this is when we have a conus arteriosus defect, when the aorta and the pulmonary artery don't separate and become individual vessels, of course, because then all bets are off. We don't have that pinching at the center. So if we look again at this one, we get a hint of where this commissure is, and we get a hint of where the pulmonic valve commissure is right here. So we know that this is the left and this is the right. So this actually, even though it looks extremely posterior and even probably slightly to the right to some people, this is a normal origin of the left cusp. What's happening with this patient is that this heart is lever rotated. So the axis of the heart is rotated in such a way that it kind of rotates the cuffs counterclockwise with it and shows us where the origin is. It's a patient with Down syndrome. Um, Antitralogy. Antitralogy tends to do this. It tends to have that lever rotation of the heart. So again, this is a normal origin, but it's a good exercise to try to see where these are. So just a quick couple notes on, sorry about that, ALCAPA, anomalous origin of the left coronary from the pulmonary artery. Historically, this was called the bland white garland syndrome. These were three cardiologists, also in Mass General, that first described and published this congenital anomaly. Rumor has it, and I don't know this for a fact, Dr. Paul Julesrud passed NASCI present, and one of the also, I guess I'm going to call him one of the fathers of pediatric angiography, cardiac angiography. He told me that the first patient was actually the baby of the chairman of radiology at Mass General that time. I don't know if I just violated HIPAA or not. That's one of the great
That,
questions.
Jacobo, that is correct. This is Sandeep here, and this is a well-known fact in the Mass General Institution that that was the case. In fact, it's a known historic vignette, and y- be assured you're not violating any privacy laws because it's been written up in the literature already.
There you go. Yeah, so it's there you go. That's a good NASCI trivia. Um, like I said, it's thank you for that. So rare congenital abnormality, again, expected in about 1 of 300,000 live births, so about a quarter of a percent, if anything, of all heart defects, not of the population. So again, very very rare, even though we just went through 5 of them. And again, usually isolated. I did show you one with an congenitally absent right pulmonary artery, so it can be associated with other congenital defects. This is a beautiful example just because how perfect they both align. And you have also that little blush of contrast coming retrograde into the pulmonary artery here. It's kind of subtle, but you can see it if you window the image appropriately. This is a 44-year-old male. So again, another adult, and you see that dilatation of the coronaries because of all of that shunting. From a physiological point of view, we talked about this. We're stealing blood from the heart. So instead of going to the myocardium, it's going to the areas of lower pressure, which is going to be the pulmonary circulation. So again, stealing and potentially creating ischemia, especially in those babies. Like I said, usually noticed in early infancy. As soon as babies need to start stressing themselves, and by stressing themselves, I mean crying or trying to feed, they can go into heart failure. And if it's untreated, the vast majority of those kids will eventually die. So this is a surgical uh, treatment for sure. Um, Again, some of the physiology, I'm just going to let you read through this in the next few seconds. But again, these are that substantial collateral flow that can allow some of these patients to survive into adulthood or even later and get treatment later in life. I found this name in the literature, subacute ALCAPA. So again, in adults, because it's not the acute phase, it doesn't happen when they are babies, and they can have all types of symptoms. And of course, this is an interesting tidbit of information clinically. The older patients that are asymptomatic, they still carry a very high risk of sudden cardiac death. And there's a series where 80% of them died suddenly at the mean age of 35, which is clearly way too young to be dying. So it's one of those cases of sudden cardiac death. This is one of those reasons that sometimes we try to screen some of athletes, not really for this, mostly for other cardiomyopathies, but definitely one of the causes of sudden cardiac death. Now, we talked about the embryology of the coronary. So there's two theories about how the coronaries actually come to place, and I think we can argue. I would like to get some insight on what you think about this. There's two theories. The first one is a Brikosov theory. Talk about septation of the conotroncus. So what they talk about is that there's endothelial buds coming off this aorta, and that when it divides, some of these buds are going to be, they're supposed to be in the aorta, but if it's abnormal septation, abnormal separation of the truncus into aorta and pulmonary artery, some of those buds can be incorporated into the pulmonic artery, and that's why the coronaries that eventually connect to them are now originating from the pulmonary artery and not the aorta. And the other one is Haken-Sellner's theory that just says that everybody has buds. There's a lot of buds, both the aorta and the pulmonary artery, and it just has, they'll just go to the one that is the most dominant. That's usually those in the aortic side of the conus, but it can be in the aorta as well. So a couple other cases from the collection here. This is a 54-year-old male presents with a syncope. They did a cardiac cath and had a circumflex arising from a pulmonary artery. So now we see a different case. It's not the left main, but the circumflex itself. And you can see here this arrow here pointing. So the left main has a normal origin. But what I find very interesting in this case is that the circumflex comes off the undersurface of the right pulmonary artery. So no longer close to the truncus, no longer close to the valve, but all the way out from the pulmonary
Making me feel like I'm taking crazy pills.
Here you see it as well, coming from the undersurface of the pulmonic artery. So pretty far from where it should have been, and very different from the other cases that we saw. And these are nice virtual reconstruction. This case actually is courtesy of Dr. Cummings, who is at Mayo now. He shared this with me when he was over at Mallinckrodt in St. Louis. And this is another case, similar history. Actually, I wrote down the same history, but it's not the same case. And you can see here the right coronary artery injection. But if you see now here where it's going, a little bit further up into the pulmonic artery, that retrograde field. And this is very interesting. If we wait long enough into the injection, we see that it's actually draining into the right pulmonary artery. We don't see opacification of the left. So it's really just draining into the right. So again, not exactly what we expected into the proximal main pulmonary artery. And this is that case, the CTA that shows where it's coming from. So it's further out and on the undersurface of that right coronary artery here. So this is an almost left coronary or left main from the undersurface of the right pulmonary artery. So my question to everybody on the webinar is, what do you guys think? Which theory best explains these variants? I'm putting here just a case of, we know that coronary arteries can occur very, very high up to the level of the proximal aorta, above the level of the sinotubular junction. We see this relatively often. So I believe that the theory that holds the best is probably the second one, Haken-Sellers, that just says that both arteries probably have just lots of buds rather than some very few allotted buds down by the valves, and there's always going to be one that's dominant. Has any comments from anyone? Any ideas? Okay. We have a shy group today. And just another bonus case here on the topic. So we have a 27-year-old female with past medical history, cardiac surgery at 2 months of age. Again, by report, it looks like it's a repaired ALCAPA, but now some chest discomfort, so they decided to do some imaging. And just going to show this. We see this vessel here. There's this lack of communication. Note there's no left main of the aorta. That's where the aorta should, the left main coronary artery should be coming off. And then we see here the arch, and we see the first branches here, the brachiocephalic arch branch, the left carotid, and then we see this branch that seems to be coming down, and that's actually a sacrificed left subclavian artery. So what they did in this patient when he was a baby, they didn't do a reimplantation. It's a different type of treatment that's very rarely used, but they used to sacrifice the subclavian and bring it back to bypass those coronary arteries. Here we see the subclavian being all the way brought down to the level of the heart. And then we see here where it anastomosis at the left main, and we see the LAD and the circ, LAD there, circ there into the heart. And another view of the same. So we see here the anastomosis. We can argue if it's a little bit narrowed or not, but that's just, again, a treatment that was used to be done and very rarely done nowadays. All right, let's go back. Any comments about those cases before we move on to a slightly different topic? All right. I do want to get some input from you guys on this case. So this is a chest CT without contrast. I do have one with contrast. I could not get it. The images seem to be corrupt in the PACS system. So we're going to try to make do with this. And what I'm going to show you here, and you're going to have to trust me in this, is that the right coronary artery is arising from the left cusp and has a course between the two right vessels, so what we call a malignant course. And this patient was symptomatic. And there was a perfusion defect, which was kind of subtle, honestly. It might have been an overcall from the person that read the study on the nuclear stress test that the patient had. And the patient was treated by the cardiologist, and I want to get your thoughts on the treatment. Let's look at this series here. So this is a gated coronary study done after treatment. And I think you can tell right away what happened there. So there's the anomalous right arising from the left cusp. But now we see that there's that metallic stent in place here. So let's see if we can see it better on a different reconstruction. Not too much. So we see it. We see a little bit of that intramural course here into the aorta, and how that would have caused a little bit of a flap effect onto the ostium of the coronary, and one of the concerns of having a coronary there. I have had, this is about 10 years out, patient is doing great. And that same year, we had a second case just like this that was treated exactly the same way, and the patient is also doing great. I have not seen anybody stent these cases since. I've only had these two cases, again, from about 10 years ago. This is clearly, I don't believe, standard of care for this. I want to get some input from you guys. Have you guys seen anybody do this in your institutions, and any issues or any concerns about putting a stent in these patients rather than doing a pure unroofing of the origin of the coronary?
Hello?
Yeah.
This is
Hi.
Captain Moldova's never seen it.
Okay, so Karen has not seen it. Dan, you wanted to say something?
Hi, this is Sandeep here. I wanted to say that I haven't seen this in my institution at MGH, but I'm aware of this particular technique being used in parts of India. In fact, a case was shared with me a couple of months ago from Chennai. And I believe the group also wrote it up in Indian Heart Journal. I have the citation, I can send it across, that talks exclusively about this technique and the follow-up and how these patients are doing great. But they too did not see any adverse events after treating. And the reason behind they going this way instead of surgery was that a lot of the patients they get are not very affording category, and because of economical constraint, it was chosen to stent these patients rather than subject them to surgery. I can send it around. I have the citation.
Perfect. Yeah, that's great. Thank you.
No problem.
Thanks, Sandeep. All right.
Mhm.
So yeah, there's no point in showing another case that looks just like this one. That's why I'm just going to show one, but I did have two of those. And then I did want to share this case, and then I'll open it for anybody who wants to continue to share cases. This is an interesting case. Young adult presented with chest pain. They did a CTA. And I guess you know what I'm going to show here to some degree. There's a vessel here already coming from the right cusp with a little branch vessel here, probably the conus branch. And then there's a second vessel as well, and a third vessel. And let's look at the left cusp again. We don't see much coming off from the left cusp here. So, and this one retro aortic vessel, right? So we see all three vessels coming from the right cusp. Interesting course of the LAD going anterior to the RVOT and then coming down into the interventricular groove right there. So that's actually the LAD coming from the right anterior to the RVOT. It's one of the less common coronary anomalies going anterior to the RVOT. It's even less common to see it the right coming from the left. That's extremely rare, but this one is very rare as well. And then you see the circumflex that's arising just below the RCA and coming in a retro aortic. So none of these three meet the criteria of the malignant course going between the great vessels, etc., etc. But there was something very interesting with this case, and I'll tell you what I said because I was asked to give an opinion, to render an opinion here. But let me show you what I said about it and why, I guess. But I would love to get your thoughts on it, and also if there's anybody from Mayo, because I know the team from Mayo wrote a paper on this. So knowing their take would be very interesting. So let's see. Let me move this out of the way. So you look here, this is the circumflex coming down, the origin. You see it has a pretty acute angle as it comes down, and it kind of narrows the ostia. It has that slit-like appearance that's been described in other cases. So it looks tight, it looks slit-like, right there, but it doesn't have that malignant course. So the question, the concern from the person that sent me this case is what to do about that circumflex. If there was a concern for enough to either mainly to do an unroofing at the origin, or maybe even do a reimplantation. I think having that almost shared origin with the RCA would preclude putting a stent. It would make it just too risky to have any of the stent struts kind of protruding into the origin of the RCA. But it's definitely an acute angle. It may have a bit of a flap here. It's very slit-like. After much deliberation and discussing this with some of my partners, we decided that this was very unlikely to be malignant coronary, but and that honestly, if the patient would not necessarily benefit from doing a surgical procedure at this time. What are your thoughts, guys? What do you guys think?
So this is Dheeraj from Wisconsin. So do you think the perfusion has any role in this case? Because when we look at the malignant coronaries, for the left, there are literature about sudden cardiac death and other risk factors. But for the right, even with intramural course, I do not think there is something positive to say that if we do not do a surgery, the patient will die.
Yeah,
so
well,
we rely mostly on perfusion and stuff like that. So do you think the same thing can be applied here?
yeah, and this is not the right, correct? This is the circumflex artery.
No, that is why I'm saying, because with the right also, you do not have any convincing literature saying that patient will die if you do not do anything. I have 2 patients in my record who are okay for last 5 years after the diagnosis of aberrant right coronary with intramural course. And they had perfusion, normal perfusion, and surgeon decided not to do anything. So do you think that can be one thing to do in this particular case? If you see any perfusion defect or stress perfusion defect, and then go for surgery?
Yeah, I agree with you. They did have a stress test which was negative, and of course that's
Okay.
make everybody feel much.
Yeah. So many people nowadays, they do that for right coronary artery. If they see that the perfusion is okay, they may not do anything, and maybe that is why that stent that many patients had similar outcome to other patients who didn't have anything.
Correct. Perfect. Thank you, Dira. Anybody else? All right. So those are the cases that I tried to put together, have a bit of a topic and some good conversation about. But if we have a little bit of time. If anybody wants for me to share the screen with them and show some of their cases, if anybody had a chance to prepare some in expectation. I know this was not marketed that way yet, but some people may have. Speak now. Okay, perfect. So, guys, so I think I lost you there for a second. Something to do with my connection, maybe. Anyway, so guys, thank you so much for joining. I hope it was worth your time. We're going to be meeting again the first Tuesday of the month. So I'll see you here the first Tuesday of March at 4 p.m. Eastern Standard Time. Everybody's more than welcome to prepare cases. We're going to be sharing the screen with everyone. Everyone can, show an interesting case or ask for advice on some of your cases. This is an open forum. It's a very friendly environment, and we're all here to learn together. I am recording this conversation, so we're gonna, as soon as it's ready, we're gonna also post it in the website, so you guys and your trainees or your colleagues can go back and try to look at the cases, and you guys can put it on mute if you don't want to hear my voice, and I don't take that personally either. All right, so thank you so much, and hope to see you next month. Take care.
Thank you so much. This is great.
Okay.
All right, guys.